The recent guidelines just came out 2 weeks ago, have exactly the same level of recommendation, and that regional systems of care should be developed in order to provide all of the therapy that we just saw. The problem is they don't tell us how to do that. We have a lot of problems in the United States, and it's not unique to us. We have multiple pre-hospital systems. In my state, I have 100 counties with 400 different EMS systems. There is no specific coordination. The air-ground transfer systems are not centrally organized across different health systems, and everybody's competing for the same patients, not necessarily in a collaborative pattern. I really like this because here's the innovator of innovators telling us that it's not just what we discover, but how we actually deliver what we discover. So whether we have these phenomenal pre-hospital artificial intelligence systems, they don't benefit the patient if they don't get the treatment. So what we've been talking about a lot this morning is we've done decades of learning what to target, these clots, and how to deliver it. The newest, latest, greatest clot extraction system, how to pick the patients. But the real challenge that I think we face as healthcare providers is how do we integrate this? And this box is what we call, this is the final integration and delivery. So this is where we're looking at implementation science. So we've been working at Duke for many years, my cardiology colleagues, as was alluded to earlier by Dr. Devlin, because cardiology basically had the same problem 10 to 15 years ago. We had lots of great PCI. In my state, only half of the patients got TPA, got thrombectomy of their PCI of the heart. The other half were getting streptokinase. Ambulances did not have EKG machines in them. They went to wherever their closest system was. And so they developed a model in cardiology that focused on three aspects of care. Who you treat, so who's the patient population that you need? What do you actually deliver in treatment, and where do you treat? So I'm going to use this model to share with you what we're doing in North Carolina, Tennessee, and South Carolina as a collaborative to integrate all of what we learned this morning into an actual delivery system. So we feel that there are three main components, and this is getting the patients to actually understand, to get the help. This is the targeted community engagement. Generic commercials don't work, and so we're going to talk a little bit about how do we get the right people to go to the right place. How do you build a system that can deliver this, and then what do you actually do for delivery? So who you treat is an area where we're looking at targeted community outreach programs. And there are various models. My colleagues in South Carolina have this great program called Holy Stroke, where they've basically created a large network of just about every church in South Carolina. And they now have them into a database. They've provided targeted education. These are very high-risk patients. In my state, I'm working on a program I call SNP Stroke, which is we're working through barbershops to teach stroke awareness and the importance of activating 911 systems. And then we've looked at a number of programs that our hospital is part of. This one is what we call the Be Fast and Pay It Forward. So we're teaching every care provider in our hospital, including the transporters, the greeters. It's now on our telephone. When you call to make an appointment with any system, you get about a 60-second commercial, not on how great we are as an institution, but stroke symptoms and recognition. All of our pharmacies are dispatching these BFAST cards, and this is what we're putting into the barbershops to teach patients, how do you know you have a stroke, and what do you do when you have that? As far as where you treat, this is the important part of the integrated comprehensive stroke center, and this is where the centers capable of providing multifaceted care can team together. So we've built a partnership with many of the folks in the audience here to tie these three states from Tennessee, North and South Carolina into one integrated system that actually captures data together, works with pre-MS systems, and then delivers optimal care. Now there are thousands of guidelines available from various institutions, and if anybody enjoys reading guidelines, it's probably like reading the rules book for the NFL. Nobody wants to do that. What you want is, with whatever your team is, whether it's the New England Patriots or whoever, what are their playbooks? What are the right things that work for them? So we've taken a distillation of AHA guidelines, data from big databases such as Get With The Guidelines, Target Stroke, and then we did a worldwide survey of the largest institutions we were aware of that were delivering state-of-the-art care, and put this into what we consider different levels of evidence, not in the American Heart Association style, but what is absolute guidelines, and when those guidelines don't exist, what seems to work? And this is done everywhere from the primary community-based hospital all the way to the comprehensive center. So this is where we get to look at our practice. Our smaller, 50 and 100 bed stroke access hospitals get to look at their practice, and are they doing what is known to be best treatment? So now we have a baseline of what we want to deliver, and putting it all together is the key. This is the implementation part. So we have partnered to get leadership from the community hospitals, from EMS systems, from hospital administrators, and create this model of care, collect data, and so this is the final integrated pathway from the community-based hospital to the EMS systems, to the primary hospital, to the transport to the tertiary hospital, and all the way to final outcomes. And rather than doing this in serial, this is all being done in parallel. One of my colleagues, Brad Coles, is doing very similar to what was outlined earlier, where we are now integrating systems such as Pulsara, with Ischemia View, with a number of different telehealth communication tools, and putting it into one contiguous database. So now your poor stroke coordinator doesn't have to extract data. Data is automatically extracted based on workflow. And now we get to test what is actually being done. And what we're doing is now creating monthly individual hospital reports that we will provide to each institution that is partnering in this collaborative, so they get to know exactly what their metrics look like. And then we compare them across, as you can see those bar graphs, without the hospital's names being put out there, so people are safe and fair to share their data, but you know which hospital you are, whether you're hospital A, hospital D, and how do you perform on each of these metrics compared to your colleagues. The model then requires us to have monthly investigator calls. The coordinators from each of the hospitals are currently meeting every week by WebEx, and we're going through best practices and feedback. This feedback also includes feedback directly to the paramedic, because if somebody came into our institution and told me they have a LAM score of 4 patient, and we examine them and that patient has an LVO that gets us a sexual thrombectomy, that is incredible real-time feedback to the paramedic that they did the tool correctly. If the patient was seizing and they weren't aware that eyes deviating towards the same size as a weakness may not be a stroke, we get to give that feedback in real time. And so we're doing real-time training and learning as we're collecting data and feeding back. It also gives you a great bully pulpit when you go to your institutional leadership, because if you don't have the capacity to do CT perfusion or CT imaging, we have 6, 7 telestroke sites that have worked with us. And in the last 18 months, we've now instituted CT angiography in every one of our telestroke sites. These are everywhere from 200-bed hospitals to 50-bed ready access. And it was the ability to compare across institutions and sit with our hospital leadership that allowed us to be able to help those institutions get the resources they needed. So at the end of the day, what is important to your patients is not how pretty this map looks or how sophisticated the artificial owl is. What's important is how your patients do. So the primary end driver of this systems of care approach is the final 90-day functional outcome of a patient. But to get there, we want to look at the subcomponents. So we've targeted what we thought at that point was fairly aggressive, that across the entire consortium, which is 10 hub hospitals with approximately 100 spokes in this system, we are looking at a door-to-drug time of less than 45 minutes in 3/4 of all the patients within the system. Our goal also is to be able to go door to first device for LVO in less than 90 minutes for 75% of patients, which our cardiologists tell us is ridiculously slow. And we've seen from Dr. Rebo and others that this can be done much, much faster. Transferring patients that come directly to us, they should be in the angio suite well before an hour of hitting your door. And what we want to do as a group is also begin to change the conversation, because we keep hearing about door to groin, door to TICI-3, door to drug, but that cuts out the entire pre-hospital system. So what we want now is first medical contact. When does that patient or their family recognize something is wrong and reach out to 911? And it's that timing, the first medical contact to definitive treatment, that we would like to see if we can get down to less than an hour in 3/4 of patients. Which means that from first medical contact to the time they're in your ED getting lytics should take less than 15 minutes. That becomes a challenge in the rural areas, and those are things we're going to have to overcome. We also would like to look at other secondary measures. One of the things that we know is extremely dangerous is the patient coming in with a hemorrhage who's on anticoagulants. And it came as a surprise to me several years ago when I started surveying our referring hospitals that the emergent feeling that was there for giving lytics does not seem to be there for reversing coagulation. It can take 2 to 3 hours to get your first dose of PCC in some of these hospitals. Some of them are still using fresh frozen plasma. You can have patients getting apixaban or dabigatran or rivaroxaban that may or may not have reversing agents at those local institutions. So again, looking at treating the hypertensive coagulopathy-associated hemorrhage with a door to treatment time that has the same urgency as the door to TPA time for lytics is part of our program. And we're going to be looking at hematoma growth in these patients to say, can more rapid, quick delivery of a reversal agent actually stop that bleed from getting bigger? And then, as I said, for our patients, the really important part for them is what happens ultimately. And we're looking both at 30 days and 6 months, 90 days and 6 months, because there's been a lot of literature recently looking at these large vessel occlusions. 90 days is too soon to look for a peak effect of recovery. So we're looking at the 6-month recovery too, to see whether, in fact, some of these slower but eventual recovery patients are impacted by our stroke system. So to summarize it, giving fair time to our Apple friends, I think this is really an extremely exciting time. We have more sophisticated tools, better lytics, better extraction devices, and now it's up to us as leaders in the field regionally, working with our collaborating partners to integrate the whole system, to create a partnership across health systems so that we can share helicopters, share transport, collect data in real time, feed it back in real time. You don't have 2, 3, 4 months to get with the guidelines data back to know whether you're doing well or not. You need to know that at the end of every month of treatment, and every provider needs to know that at the end of every individual case of treatment, how you're doing, so you can adjust, tweak, modify. And with that, our deep belief is that we're going to truly make a difference as we continue to work at the detection tools and the treatment tools. Thank you.
All right, one please. I would like all the speakers to come out to the podium. We have close to 20 minutes for question and answer. And the audience was very active sending us the questions, which was great. So we're going to try to sort them out and try to get through most of them. I don't think we can get through all of them. That's how many questions we received. So as our speakers are getting on the podium, there is a notion that advanced imaging deselects patients for treatment, and I'd like to open the discussion by saying something provocative. So particularly after listening to Tudor's talk, at any time window, and as more I'm looking at the imaging, time is becoming less and less relevant. So what else do we need at an extended time window more than aspects of 6 and the proof of proximal occlusion? Do we need anything else than aspects of 6 and the proof of proximal occlusion to move the system fast?
In what time window?
Any.
Well, I mean, I think I see selection different in the early versus late time window, because in the early time window, you're dealing with you're addressing the fast progressors, right? So those are about 50% of the patients that we're dealing with, 60, 50%, whatever, and clearly those get punished most by delays in reperfusion. So my question is, do we need any aspect? I mean, let alone 6. I think there are several randomized trials going on. I think it's good to do them. But in the meantime, the evidence that we have suggests that it doesn't matter what your aspect score is. Just go. And even if there is no benefit, it's unlikely that there is harm overall, right? Some patients we do harm, but overall it's unlikely that there is harm. And so by reperfusing patients faster, because we don't do imaging, we're going to have helped the vast majority who have good aspect scores, right? So I think in the early time window, my feeling is that don't ask questions. Just reperfuse, okay? Reperfuse first, ask questions later, okay? In a late time window, beyond 6 hours, you're dealing with mainly fast progressors. You have some time there. And, with the slow progressors, you have some time there. And I think that what we need to do, I think we have some good correlation studies between aspect 7 and a score greater than 70. That's where we are. I have no hesitation treating a patient with an aspect score of 8 and above without any kind of advanced imaging in the extended time window. But I do think that for the lower aspect scores, we should do some further trials and clarify how low could we go. It doesn't make sense to me that we can go to aspect scores of 0 in the extended time window either. Okay. There has to be a threshold.
Related question, aspects 0 to 4, you showed SICH rate of 19%. Do we need a trial in that subgroup, or it would be too messy?
Okay, but if the net effect is positive,